Welcome to another webinar sponsored by LymphaPress. I am Brenda Viola, and I'm honored to be your host and moderator today for a topic that has been really a focus of many of you. Both patients and clinicians who are in our audience have requested that we talk about the central lymphatics. As you are all logging on for today's webinar, I hope that you will please let us know you're here in chat. A little bit of housekeeping. This webinar is being recorded. It will be posted on the LymphaPress YouTube channel, and everybody who is registered will receive a link to the replay. Without further ado, I want to announce that Megan Asher is our guest today, and I found her through Dr. Itkin. You work closely with Dr. Itkin, don't you, Megan?
Yes, I am the nurse practitioner who works with him. We are a team of two. We also have another physician, Dr. Nadolsky, who works with the lymphatic program, and then Patty Hetherington is our administrative assistant. So we are a team of four. I do all the inpatient work and outpatient management of all the patients.
Well, we feel so fortunate that you are with us today. And without further ado, this is being recorded. If you don't get it all today, you will get it on the recording. We will do questions at the end. And Megan, thank you for your patience. Everyone, thank you for your patience. Take it away.
All right. Nice to meet everyone. Thank you so much for giving me the opportunity to speak with you today about the decompression of the thoracic duct and all the sequelae that happen as a result of what we have now found to be the thoracic duct obstructions in patients. So if you look at the main lymphatic system, it will, you will see that the lymphatic system's function is to remove the proteins and waters and move it back into the tissues, from the tissues back into the veins, starting from down to the interstitium and the capillaries. And as it moves back into the thoracic duct from the lymphatic system and into the subclavian vein up in the neck. The lymphatic system has small amounts of contractility along the vessels that have some small valves. And so when some of those start to fail, even though they're not strong like you have in the venous system, the arterial system, that they have large valves, the lymphatic system does have small valves and some contractility, even though it's not very strong. It's not something that you can replace as you can with others, but it does have some contractility in order to be able to move it forward and back up into the venous system. And when the lymphatic system has issues, or that the main function is to remove the fluid back from the tissues into the venous system, we're unable, as you can see here, like the fluid leaks from your capillaries back out into the lymph system and doesn't go vice versa. You can't, as you know, lymphedema, you can't have fluid go back into the venous system as significantly because of the pressures. The lymphatic system, the only body system that can remove fluid from the tissues. And there's no reabsorption from the venous system along the extremities. So as we go through, what we are looking at are what are the different types of lymphatic flow disorders, and how do they then relate into different types of leakages from the lymphatic system. So the lymphatic leakage can come from, they can leak chyle, they can leak soft tissues, and then they result in a groin and abdominal swelling, or a lymphocele could be. The scrotum could have scrotal lymphorrhea, which is lymphatic fluid leaking from the scrotum out of the skin. The liver and the intestines could cause lymphorrhea and protein losing enteropathy if the fluid is leaking into the intestines. The other portion, the chyle, can leak into your pleural cavity, causing the patients to have a chylothorax, into your bronchial trees and causing plastic bronchitis, which is the hardening of the fluid into your bronchioles, and then chyle leaking into your abdomen or into your kidneys, causing chyloscystitis and chyluria. And these are all the different types of lymphatic leakages that we look at. So then we say, well, what is the reason that these are happening? And most oftentimes we look at where they are leaking, and we have now discovered that there's a lymphatic obstruction in the distal thoracic duct that then causes patients to have develop collaterals and causes them to have lymphatic leaks outside of their main central lymphatic system. So then you go back to here into the types of lymphatic flow disorders and where their leak is coming from and how does it work. So lymphatic obstruction in your distal thoracic duct can then go backflow into your central lymphatic system or into your peripheral. We don't mostly look at the peripheral system. We look at the main thoracic duct and the obstruction and what does it cause. We now know that an obstruction of the thoracic duct can cause a chylothorax, classic bronchitis, ascites, chylosascites, and protein-losing enteropathy, known as PLE. So in lymphatics is all plumbing. Similar to the other vasculatures, whatever is open, we used to close it, and whatever was closed, we need to open. Until recently, we only used to do embolizations, and in the past 3 years, we have discovered the thoracic duct obstruction that causes a backflow of the lymphatic system. It causes the collaterals that then leak and cause pressure into other systems. This here is a video of the thoracic duct venous junction and the anastomosis when it gets sewn together. That's how small this is done by our microsurgeons, and then what it looks like when it's done. So here is the connection. That's the thoracic duct getting connected to a vein, and how small this is over here, and now how large of a connection it can be, and the flow of the lymphatic system that then will decompress the rest of the central lymphatic system. And so this is the anastomosis, and how nice that looks afterwards, and how large of a connection, as you can imagine, from what was obstructed to now how open it is. This is what that patient looks like as a result of after what their flow looks like in lymphangiogram and interventional radiology. The surgical decompression of the thoracic duct and venous junction is not a new concept. This was described back in 1966 when people looked at liver cirrhosis, and that they had thought that the liver cirrhosis was a result of the thoracic duct and venous junction obstruction, causing a backflow and causing hypertension and cirrhosis into the liver. They considered it to be a high resistance point, and the thoracic duct, they had offered bypass, just as you can see here, that the dilation of the thoracic duct at the distal end, and then they connected it to the IJ. Again, here another old publications of patients who have had the described old literature of patients with the thoracic duct venous junction bypass surgeries, and they had some success. Some were more do describe it to be 100%. These were for patients mostly with liver cirrhosis, and as you can see here, the patient who had ascites, and now they look completely better back in 1975, and their ascites was fixed as a result of the bypass surgery, and no longer needing having that hernia as a result of cirrhosis. But why do people not talk about it? Why does this seem to be a new concept again? Patients, they didn't have good patient population that they had done before. And ultimately they came up with the TIP system or Denver shunt or Levine shunts as less invasive alternatives, because it's very technically difficult to do the bypass surgery. And it was forgotten about that this was not, it was too technically difficult to do it. And patients were not good surgical candidates in the sense that they did not actually have good imaging to see the distal end of the thoracic duct as a result of the cirrhosis. And they ultimately decided to do other less invasive procedures. So it has, again, been forgotten about over the last several years. But, we can do this again. So yes, we can. We have new technology to be able to image patients. Most importantly, we are using an MRI lymphangiogram, CT lymphangiogram, and we use interventional radiology in the operating room for guidance during the bypass surgery with the microsurgeons. So here, the different types of decompression of the thoracic duct and the venous junction. You can either do the surgical bypass, which is the video I just showed and we'll talk about. We're doing a balloonplasty, a lymphoplasty, or there's stenting, and they're all described with different success rates. So what is the indications for this? Again, indications for thoracic duct decompression, the ascites, going whether it is from liver cirrhosis or chylous ascites, protein losing enteropathy, patients with chronic abdominal pain or lower extremity lymphedema. And we're going to look towards, in the future, patients who have congestive heart failure and more ascites from the liver cirrhosis. And our experience with the thoracic duct obstruction that is causing a significant back pressure. And that is the reason why the patients are then having ascites and the lymphatic leakage disorders as a result of their obstructions. And some of those patients have acute and chronic abdominal pain, their lower extremity edema, and protein losing enteropathy. So why do patients have the thoracic duct obstructions? Truthfully, it's not something that we can pinpoint specifically to say that you will have it, you won't have it. It's not easy, as I said, to be able to diagnose it. Some patients have congenital stenosis, that they were born that way, and then they just started to have symptoms later in life. There is debris that we have found that is as a result of patients who have had surgery. So they had a hip replacement, they had a wedge resection, and all of a sudden they wake up from surgery and they have lower extremity lymphedema. And those patients have what we say is debris. We don't know what that debris specifically is. Not so much as like a clot, but there's just something, it's not like something that was left, but it was something that had just occluded their thoracic duct, and we're able to flush it out. A venous occlusion, such as patients, are patients who have pacemaker wires or central venous catheters as a risk and cause stenosis of those of the thoracic duct venous junction. That's somebody who may have had PICC lines or had a dialysis catheter cause some injury to it, or just an iatrogenic injury as well. This is a patient with debris. As you can see here, they just have something floating, and this is the distal end of the thoracic duct into the venous junction, and it's just floating there. We don't know what it is. That's why we just call it debris. And here is the flushing of the thoracic duct at the venous junction, and the debris just hanging out there, and what it looks like afterwards. Then there's congenital stenosis. So this patient, this is the distal end of the thoracic duct, and this is more central into the chest. But why is this like so stenosed and tiny here? That is also considered part of an obstruction. And then a patient here who has surgical clips at the end of the thoracic duct. And that was a reason for, they had a hibernoma removed from their neck with an injury, and the surgeon then clipped all the area and in turn clipped the thoracic duct. And here, as a result of central venous catheters and pacemaker wires that have caused the injury to this area here. How do we diagnose a patient with thoracic duct obstruction? As you can see here, this is a MRI lymphangiogram. Gadolinium is injected from the lymph nodes in the top of the thigh. Contrast is ran through the central lymphatic system. And here is shown the dilation of the thoracic duct and how tortuous and that it can be as a result of having this obstruction there at the end. The MRI lymphangiogram is one of the easiest ways to see the first indication that a patient may have a thoracic duct obstruction. They're very skilled and needed to be done at specialized centers. That you can't just walk into like a regular MRI center because the injection of the lymphatic system needs to happen in the lymph nodes in the thigh for the contrast to run. Very different than having an IV contrast for a CAT scan. And this patient, honestly, this looks, even though it's tortuous and slightly dilated, it doesn't have a large dilation at the venous junction, but it just kind of cuts off at the end here a little bit. It's not so much going straight through. Looks pretty close to normal. So it's not always perfect for having an MRI lymphangiogram because not all the patients will show definitely. MRIs are very suggestive that they have, and we like to see that a patient will have the dilation or a very tortuous thoracic duct as a result of an obstruction, but not every single patient does. And sometimes they just look pretty close to normal. A very normal thoracic duct would be a complete straight line. This is like slightly tortuous. So it is suggestive in that sense, but not every single patient with an obstruction. And we would be able to see that in a regular lymphangiogram if we were going to do a procedure on a patient who may have a leakage disorder that needs to be fixed. So invasive pressures and flows, like why can't we just do something easy like a nuclear medicine scan to be able to see that? Because it's very difficult to see the lymphatic system. It has low pressure and low flow. In some patients, it may take 5-6 hours for any contrast to go through their lymphatic system. And other patients, it's very fast. So if you have an obstruction, you may never see the flow of their central lymphatic system. It's actually very similar to like the urinary system. We can evaluate it as other patients in other institutions may have nuclear medicine scans, and here you can see that. But it's not ideal because it takes such a significant amount of time, and most places don't have the time to be able to do that. We are looking at the possibility of doing similar again to nuclear medicine, a PET imaging in which you drink the nuclear medicine contrast and are able to see the thoracic duct and the obstruction at the end. This is a picture of like a patient who was in a study. But it took 4 hours for that healthy person to be able to see the flow of their thoracic duct. But again, it does not take a special institution to be able to have to inject the thoracic duct or the lymphatic system, and this will be able to be incorporated into other places around the country and be much more repeatable for those patients. Lymphatic plumbing, again, is similar to vasculature. So whatever's open, we try to close, and whatever's closed, we try to open. Until recently, we've always embolized, but now we're looking at opening. So the lymphatic system is what drains all the fluid from the interstitium. So you have the accumulation of fluid into the different cavities, which causes cirrhosis and ascites, and then edema patients who then ultimately get heart failure, anasarca, and lymphedema. So what are the lymphatic flow disorders? It's all about the obstruction and whether or not it comes congenital or it's an iatrogenic. Looking back again, thoracic duct, the surgical options or all procedure options for these patients include bypass surgery, balloon lymphoplasty, and stenting. So patients that we have found who have had severe abdominal pain, as you see this MRI again for this patient with a very pronounced dilated thoracic duct at the venous junction. Patients who have abdominal pain with causing them after eating, specifically higher fat foods, to have severe abdominal pain and bloating. It has mainly been, and this is showing like a cartoon picture of what it looks like to be able to do the the lymphoplasty, the opening of the distal end of the thoracic duct at the venous junction for these patients. See this? The balloons, the snare going through the distal end of the thoracic duct with nothing going forward. The following up of that. See the snare getting how it works. This is the interventional radiology procedure. And that's what it looks like. Again, there's the cartoon picture. The previous one was what it looks, taking the snare, taking the balloon, taking it down. Again, what it looks like in interventional radiology. And then here's where the balloon actually happens. This is up near the subclavian vein, and ballooning this open to 5 millimeters. And again, the balloon opening of the thoracic duct here, and then this patient had complete resolution of their symptoms after the balloon opening. Even though this does still have this large dilation, you can see the flow afterwards that was not there previously. It's a very extreme case in the sense that they do have this large dilation, but now had flow. So this patient had had abdominal pain, bloating, and distension after eating, specifically high-fat food. They were referred to us for an evaluation, who also had from somebody who knew what we were, just to give an idea, because their symptoms were so extreme. This patient then had, again, complete resolution of their symptoms after the lymphoplasty of their thoracic duct. We went back and looked at these patients that we had seen and treated. They were all female. They're ranging from ages 23 to 60. They were referred to us for abdominal pain. And they had, the reason that they were referred to us, not only from the abdominal pain, but some had gone in for surgery, such as they had an ovarian cyst, and the patients found that they had lymphatic fluid in their abdomen. Somebody had had a nephrectomy, they found fluid in their abdomen. Patients who have had just swelling in their neck. Another patient who had edema of their abdominal wall. All of these 8 women who we had treated were all with abdominal pain, bloating, and distension after eating, again, specifically high-fat food. We found that on the lymphatic imaging, which was the MRI lymphangiogram, that they all, half of them had complete occlusion, no flow, and half of them had stenosis of their thoracic duct at their venous junction. They also all had retroperitoneal edema on their CAT scan. So another finding for these patients, but we don't find that for all patients. They have the CAT scan findings as well. Here is the bowel wall edema, as you can see, indicated by these arrows. And they had, you see these different patients, the stenosis, their dilation, and so forth, and the flow after. Here's their flow and their different surgical points. As you can see, this very, very stenosed thoracic duct here. And the different variations of what each of these patients were, what their thoracic duct looked like, but they were all having the same symptoms. So in the end, for these 8 patients, and this study is going to be printed shortly in the radiology journal, is that six of them had lymphoplasty in interventional radiology. And they had complete resolution of their symptoms. So we ballooned open their lymphatic duct. 5 of them had improvement without reoccurrence, and 1 patient had a reoccurrence of their symptoms, and they went on to surgery for the lymphatic bypass surgery. Some of them did not. One patient went on a low-fat diet and then had clinical improvement, and one patient had a reoccurrence of their anastomosis after surgery and had to get repeat surgery and had a complete resolution now of their symptoms. So we have found that these patients do have a reoccurrence after their lymphoplasty, but ultimately they did go on to have resolution of their symptoms. Here's a patient who had lower extremity lymphedema. Let's see there. After waking up from surgery. And it's showing, sorry, here, that there's no flow and the stenosis of their thoracic duct. Sorry, get this video working a little bit better. That was not so good. Here is a patient who had ascites and renal failure. See, there's no flow here. After their procedure, the great flow into their subclavian. No flow and then flow. See them go again. Just staring at the balloon. Here's the ballooning open there. Right there at the subclavian. And resolution of their ascites within a few days. It's a great picture of the end again, and the flow of their thoracic duct afterwards. So then we looked at other patients, not only from the abdominal pain standpoint, and then we looked at what else, what other symptoms of the lymphatic leakage disorders do we see that these patients, instead of closing them, embolizing their thoracic duct, are they, do other patients for other symptoms have the thoracic duct obstruction, since we had seen that they had done so well as a result of the lymphoplasty. So we never looked at it before with patients because, again, we are in the business of closing all the lymphatic leaks. So we then, for new patients that were coming in, we examined the distal end of their thoracic duct and started to look at that. So patients with, again, the ascites, protein-losing enteropathy, this neck swelling, a chylothorax, and did a lymphoplasty on them. We had mixed 80% success for these patients, and it's not perfect. The 23 patients, 6 of them had complete resolution after the lymphoplasty of their thoracic duct. 13 patients had complete resolution, but then their symptoms reoccurred, just as in the other patient population. 3 patients had symptom resolution, partial symptom resolution, but not perfect. And 1 patient had no improvement as a result. As you can see here, the symptoms, the median reoccurrence time of their symptoms was 14 days. They had, and then the patients with partial resolution, like 1 patient had their lower extremity edema persisted, but their scrotal edema had stopped. And that some had some abdominal pain, but it got better. And those patients, then we have a patient with protein-losing enteropathy. This patient had had protein-losing enteropathy and ascites with occlusion of their thoracic duct. See here. Protein-losing enteropathy is very difficult to treat. It is the leakage of lymphatic fluid within your intestines. Most of it is symptom management for these patients. They have hypoalbuminemia, lower extremity edema. Some patients have, again, lower extremity lymphedema, hypoalbuminemia, diarrhea, and malnutrition. It's diagnosed by having hypoalbuminemia and an alpha-1 antitrypsin stool sample. It is something that 5 years ago we used to say, we don't think we can treat you. It's very difficult to find where the leak is coming from. And now we are, and it's all medical management. We've now found that patients have, they have a thoracic duct obstruction, and we're able to offer these treatments and be able to help fix their thoracic duct obstruction and protein losing enteropathy, changing their life, in the sense that they no longer have diarrhea, they no longer, their albumin corrects, and then they their lymphedema goes away as a result of having the improved nutrition. Then we think about, well, it's not perfect. Why? If we do a lymphoplasty in all these patients, again, only an 80% success rate, why do all these patients have a reoccurrence, and how can we fix it? We don't know why their symptom, the lymphoplasty is not perfect. So we think about stenting and what did other people do in stenting, just as they do for the heart, because it seems like the most reasonable. Instead of having to go for full surgery for the bypass, can we stent the thoracic duct? Patients, here is in the last 5 years, a significant amount of research and case series that shows people who are stenting the thoracic duct, but their results are not promising, unfortunately. They have stented for chylothorax, plastic bronchitis, liver cirrhosis, ascites. The first one, they had 2 cases in 2017 that you can see this very long stent of the thoracic duct, and they had no follow-up imaging after they stented the thoracic duct. This is the only one that they had. Another case, again, one patient, and they had with a very long stent, and they had no follow-up imaging after their stenting. 2020, another one patient with no follow-up imaging afterwards. Again, 2022, there is no visualization after they placed this very long stent for varices. And then again in 2022, they showed a patent thoracic duct afterwards for chyluria, but they did not show, you can't see a stent as a result here. You can't see a stent in the patency of the stent in an MRI. And the largest one recently with 9 patients, they had 3 patients with resolution of symptoms, but again, they had no follow-up imaging afterwards. So why are all these patients getting stented and they're showing success, but without any follow-up imaging? We don't know why they haven't had anything further. You have to, because you're unable to see a stent patency as a result of an MR lymphangiogram. It needs to be another lymph angiogram to see the full flow, as you can see here. So we are not stenting yet because we haven't been able to see, as a result of other papers, that patients have patent stents after for follow-up. So they can say that they did stent it and patients had success, but there's no follow-up to that to know that it truly is successful. You have to catheterize the thoracic duct afterwards in order to see a state, or do a CAT scan lymphangiogram, which we do not do right now. Other institutions do it, but they have not shown the follow-up results. So we want to do it, and we are working on it, but it's not quite there yet. It doesn't show that it's widely spread throughout the country as something that is a standard of care anywhere. An MRI lymphangiogram cannot show the area of the stent. It can show that if things are patent, but not the actual stent, if things are going or not. So what do we do? How do we help these patients with these lymphatic leakage disorders and with the obstruction of their thoracic duct, causing them to have plethora of lymphedema, abdominal pain, chylocystitis, and what are we doing to develop what's next. So Dr. Icken is working on the thoracic duct stenting in pigs. As you can see in this small, he has one long stent here and a shorter stent here, just trying to see how to perfect it, what makes it better, because this would be the easiest, not easiest, but the more logical thing to try to perfect before doing the bypass surgery, since we have found that the lymphoplasty is working for these patients with the obstruction, but they are not long-term solutions for everyone. And here is the flow after of the pig studies here. And then in some patients, they don't have any thoracic ducts. These are children who have no flow of the thoracic duct. So what do we do for those patients that are completely, as you can see here, there's nothing that flows, and the difficulties with those cases? What do we do for those patients? Even though patients may not have a central lymphatic system like a whole thoracic duct, they do have a cisterna chyli. So your cisterna chyli is located in your abdomen. It's like, but their flow is not going forward. So those patients, you know, if we're doing a thoracic duct obstruction in their distal end of the thoracic duct, and we can do a lymphoplasty and we can do a bypass surgery, what about those who don't have anything? So we think about the fact that, can we bypass them into their IVC, into their abdomen? Yes, it is very difficult to do. And these patients need to, here is the snaring through from the thoracic duct, like at the cisterna chyli, to the IVC, and connecting those two together. So the patients who don't have the central lymphatic system are draining right into their IVC. And it works. This is a child as well. Let's see. And they have success and to completely decompress their obstruction. Here's then their flow and the connection to the IVC stenting over. So there is hope for those patients. The difficult part about this is being able to access the thoracic duct at that spot. It's not a percutaneous procedure. The patient, it's usually an X-lap or a thoracotomy in order to get to the site. So not an easy thing to do for the anatomy for these patients. There's a good picture of the video of the flow. So it stops here, and now it's flowing into the IVC instead of at the subclavian. And complete resolution of symptoms again. So then we look at what other things can we do. So those patients who have heart failure and lymphatics, there's a huge potential for interventional radiology. And what is the flow for those patients who are then having lymphedema and the as a result of heart failure, and that it's possible that these patients all have obstructions of the thoracic duct that's causing a backflow, causing them to have, again, there's no venous fluid reabsorption. And the lymphatic system is the only one that removes it from the tissue. So if we can get these patients with heart failure to decompress their lymphatic system in order for them to not have lymphedema as a result of their heart failure and failure to pump, we really think that this is something that we're going to be able to work on significantly in the next year or two to offer to these patients, as we now find that there is such a huge population of patients who have the thoracic duct obstruction causing so many symptoms. Again, talking about patients with heart failure and the decompression of their lymphatic system. So the CHF, again, is a pump failure, causes the increased venous pressure, and then whether or not they have the increased lymphatic flow or are they having the decreased lymphatic outflow causing their lymphedema and tissue congestion? And if we are able to decompress their lymphatic system, would it improve their lymphatic outflow and to decrease their tissue congestion and their lymphedema is where we are looking for the next patient population. And so again, the lymphatic thoracic duct venous junction decompression is getting very, very popular from our standpoint at Penn, and what we are doing in other institutions as well. That if we can decrease the lymphatic obstructions and improve their flow rather than gluing as we used to do for all these lymphatic, patients would be here for weeks to months trying to find where their lymphatic leak is. And if it's something that is small, the lymphatic leak from protein losing enteropathy mainly, and some of the ascites patients, we are able to improve their flow and then their lymphatic leaks no longer happen. We have shown that we have had a lot of success with doing thoracic duct decompression through the lymphoplasty, but also then for those patients who have failed and have gone to bypass surgery with our microsurgeons and have complete resolution of symptoms. We would like to try to stent. No studies have shown that they are very successful with stenting of the bypass at this point in time. But we are working on those to be able to get more options for patients and develop ourselves to be able to see CT lymphangiogram in an easier way as a follow-up for these patients. Thank you.
I just want to thank you so much for that thorough presentation. I know a lot of us were sitting on the edges of our seats. I found myself in the videos where you could see that there was no flow. I was almost holding my breath because I can only imagine how the patients feel when they're going through that. Thank you for the videos as well. And two things that were underscored for me, and then I'll go to the questions from our audience. But thankful for the videos and for the technology, which has advanced the study so that we can treat these patients better. So that's the plus. And the other side is how much we still don't know. For you as someone who is immersed in this field, that must be alternately exciting and frustrating.
Yes, it is. It's hard to be able to say we don't know why this happened, as it is for any patient if you don't know the cause of why their issues are happening. But we are fortunate that we are able to offer solutions at this point. Even if it's not a permanent solution, we know that it can be, through multiple procedures, unfortunately, but patients are having complete resolution of their symptoms.
I love hearing that phrase, complete resolution, and I bet you do as well. We have both patients and clinicians in our audience today. And there is one patient who is very actually dear to us at LymphaPress. He appears regularly on our lymphedema patient roundtables. He is a vocal advocate for the lymphedema community. His name is Kelly Bell, and he has a particular interest. You know Kelly, I'm sure. He has a question. He says, in this presentation, all bypasses were in the distal lymphatics. Are there limitations in reference to where the blockage is located in the thoracic duct to doing the bypass surgery?
Yes. So they are all in the distal thoracic duct that we have found where their occlusions are. There we have had just the stenosis that I had shown in the one picture down in the chest was unable to get to that patient in their stenosis in their chest. And we do not, patients the one who we did the IVC stenting for in a child was, now I should say we've done one adult and one child now since I have said this, that they did not have thoracic duct continuing past their cisterna chyli, but all the obstructions have been in the distal end. And it is important for the patients to also have good anatomy to be able to access their thoracic duct at the distal end, because if that's why we have to do a lymphangiogram in interventional radiology first, because we have to see if we're able to access that if needed by a surgical means. If they're too far down, like down into their chest, then we're unable to access that at this time. But working on other ways to access from a technical standpoint.
We're going to actually have to have you back as you discover and learn more things. We want to hear them. Thank you for that. And by the way, you can stop sharing your screen so we can get more. That's fine. We're getting more eye contact with you, which is great. We have a few more questions. There's an anonymous attendee who asks, first of all, he or she says, great presentation. And I agree. Could a highly trained physical therapist be able to do body work to help release the TD to avoid the surgery? Are there any non-surgical methods that could help to manage this and the edema, etc.? And finally, you are doing great work. Thank you so much.
Oh,
so
thank you.
Is there body work that can help?
No. We have found a lot of our patients, most specifically the 8 women who we had discussed with the abdominal pain, they had come from our physical medicine and rehabilitation physician, that she had recognized that she believed that they had some type of lymphatic obstruction, but they were not having relief from their manual lymphatic drainage. And even though they worked on these patients to try even harder, very aggressive, if they were in their bodysuits and using the machines overnight, they were not unable to do that. It's not so much, even though it seems like if you just flush the thoracic duct, as I had shown in one of the examples, that they were not, you can't like just force it. So we have seen in the sense of doing an MRI beforehand, doing very aggressive manual lymphatic drainage, and then doing an MRI afterwards. We haven't done that, but we haven't seen patients who have had relief of symptoms completely as a result of like manual lymphatic drainage therapy.
So there's a great follow-up question to that point and 2 other related questions. I promise everybody I will get to you, but I want to jump to Kathleen Lisson, who asks, then would you say that MLD and treatments work much better after the surgery because the path is now open? How soon after surgery can a patient resume MLD?
They can resume immediately after any interventions that they have. Patients usually have a complete resolution of symptoms within a week from their lymphedema. And as some of the patients, they've lost 20 pounds in a week.
Oh my.
Yeah.
That is tremendous. And it offers such hope. And for all the therapists out there watching this presentation, right after the surgery, you can get right to it. So that's what you're saying.
Yeah.
Now, you mentioned the body work will not affect positively when there's no flow. Are there any other interventions possible if someone is not a good candidate for surgery? Judy Green is out there and asks that question.
No, not, we haven't, I don't specifically work on the therapy side of it. I do mostly all the interventions, but they can, as everyone who has a thoracic, if they have a thoracic duct obstruction, they usually have like an abdominal distension or they have abdominal pain along with any type of lymphedema. So they may improve, week to week, but their symptoms reoccur, and the ongoing abdominal pain or abdominal swelling has been the other part that does not get better. Even if like with compression or MLD, they do get better, get better for a short time and need ongoing therapy.
We had a response in chat that there is applause for the medical community that is really learning about this and helping patients. Are there many? I mean, is this?
They are, yes. And most of our patients right now are coming from our physical medicine and rehabilitation physician who is recognizing this. And then we're it's about to publish next week in the radiology journals. So we anticipate that we'll be seeing more people.
Okay, so how can a certified lymphedema therapist find a surgeon to help their clients if they think they have this issue?
It would be an interventional radiology or a plastic surgeon who does microsurgery would be, but it would have to be in conjunction with interventional radiology who have a lymphatics program.
And then further, how can people contact you and your team?
Yes. Yeah, I can give you our contact information for to be able to get in touch with us if somebody believes that they have the obstruct or have a patient with thoracic duct obstructions. Or
yeah, if you want to, do you want to offer that to us right now, or do you want to provide it later that we can put it in the
yeah, I can put it in. Do you want me to just chat it in? Is that the easiest?
You can chat it in, and I will write it down to make sure our graphics person puts it in when they edit and upload this to YouTube as well.
It is my administrative assistant, 7, 8.
Amy, while you're doing that, Amy Rivera, who is also a champion for lymphedema patients everywhere. She said she was able to unblock the left side blockage with bodywork, deep MLD, and singing bowls. However, it didn't fix her issue. Her abdominal swelling and pain did, however, improve. So thank you for sharing that. And I also see the name Patty Hetherington, which is a contact. I'm going to put
my administrative assistant. That's what I put in.
Okay, I am going to put this in chat for everyone, and they're probably going to furiously write down notes right now so that they can contact you. We also have distinguished leaders in our audience today, and I've already mentioned several of them. Catherine Seo is out there who has done so much for the patient population for both lymphedema and lipedema in particular. She says, great presentation. What is the success rate for bypass surgery, and does it last? Just to understand.
We are just about 95% right now with bypass surgery. And the 2 patients that have not had complete resolution have had just very difficult, strange anatomy that was not conducive to bypass.
Wow, great odds. That's what Catherine is saying. That's what we are all saying. This was a presentation that truly needed to be offered today. And we know that your time is valuable. We thank you for offering your time to us today. Everyone, if you registered, you will get a link to the replay. It will be posted on the LymphaPress YouTube channel. If you subscribe to the LymphaPress YouTube channel, you'll be alerted as soon as it posts there. This was excellent. We again applaud you, Megan, for the work you are doing. Please give our regards to Dr. Itkin, and we hope to have you back on this platform in the future. And with that, everyone, have a wonderful rest of your day. Thank you for honoring us with your time and joining us for this webinar. We'll see you soon.
Thank you.